Good morning, guys. I'm going to tell you what to expect for your exam on Monday. And again, you'll be taking the exam after the Sim Center. So 9 a.m. Sim Center, and then I think I said 1:30, 1 o'clock or 1:30 to start your exam once you arrive at your house. So you need to review your congenital heart defects. Inhaled nitric oxide. ECMO. And Velletri. Okay, and then to be more specific, for congenital heart defects, go through all of the different defects, be able to understand how the blood flows differently because of the defect. And then after you're comfortable with that, I know I gave you the handout. Some of the diagrams from that handout are on the exam, and you have to look at the diagram and identify the anomaly or the defect. So make sure you know you're familiar with those. You have to know if the defect is causing the blood to be shunted left to right or right to left. Some of the defects need a patent ductus arteriosus in order to get some blood flow into the pulmonary vessels, or to relieve the high pressure in the pulmonary system. So it can go either way. You need to get blood from the pulmonary vessel into the aorta, and some of the defects you need to get blood from the pulmonary artery. And did I say it backwards? Aorta to pulmonary artery, and then some of them pulmonary artery to aorta. All right, and then specifically, so let me type that in. Wow. It's in my brain, but it's not my fingers. Cyanotic or decyanotic. Identify the diagrams that I gave you on the handout. Some of them show up on the test. Okay, so those are the general questions, and then some specific things to focus on. For AV canal, why do we keep a low oxygen saturation? All right, there are some situations where we have to keep the babies hypoxic other than AV canal. So let me rate that as a question. So remember what the response is of the pulmonary vasculature. So having low oxygen saturation causes the pulmonary vessels to constrict. So we take advantage of that fact. And if we want to decrease the amount of blood flow going through the pulmonary vessels, keeping the baby hypoxic will achieve that. So some of the defects that we talked about was tetralogy. No, not tetralogy of Fallot. Hypoplastic left heart syndrome, where we want to keep pulmonary vasoconstriction going and that'll force the blood through the ductus arteriosus into the aorta. So with hypoplastic left heart, there isn't much blood coming out of the ventricle because the left ventricle didn't develop. So how do we get blood to flow to the aorta? The blood can flow to the aorta through the ductus arteriosus, but we need a high pulmonary vascular resistance in order for the pulmonary vessels to have a higher pressure than the aorta. And that'll cause the blood to go from high pressure to low pressure, meaning pulmonary vessels to aorta. Okay, next specific question. Where's my... what drug will cause the ductus arteriosus to close? And what drug would we use to keep the ductus arteriosus open? Right, next specific question is treatment for TET spells. So when a baby is born with tetralogy of Fallot, the pulmonary artery didn't develop. So not only that, the aorta is taking blood from the right ventricle, from the left ventricle. The more blood that's coming back to the right heart and getting into the aorta, the more desaturations the baby is going to have. So if we have a lot of blood coming back to the right heart, a lot more deoxygenated blood will get into the aorta. So to prevent a lot of blood from coming back to the right heart, morphine helps because that's a venous vasodilator or just a vessel. Yeah, mostly venous. Venous vasodilator, that'll keep more blood in the veins and less blood coming back to the right heart. We talked about pulling the knees to the chest, and that puts some pressure on the veins that are taking blood back to the right heart. So you'll have less blood flowing back to the right heart because you're squeezing the knees up to the chest. Another way to treat TET spells is to deliver 100% oxygen, get the pulmonary vessels to open up. So you can get a little more blood flowing to the pulmonary vessels and not all of it going directly into the aorta. So that was your treatment for TET spells.
Yvonne, for the TET spell treatment, do they usually try like a combination between putting the knees up to the chest and like morphine or the oxygen?
Is it a combination to treat it? Yes.
Thank you.
Anytime. And then there's a question, which of the following are ductal dependent cardiac defects? So ductal dependent defects, you need the ductus arteriosus to stay open. So I don't know if I can shout out the answer and be complete as the notes. So I'll defer to your notes on that. I know that with hypoplastic left heart, you need a ductus to get blood into the aorta. I know with tetralogy of Fallot, you need to get blood into the aorta since the pulmonary vessel, or you need to get blood into the pulmonary vessels because the pulmonary artery is underdeveloped. And then transposition of the great vessels. There are two completely separate circulations when that happens. And it's only the ductus arteriosus that allows communication between the two circulations. Okay, I think I'm missing one. So you'll have to check your notes. All right, so that's it for congenital heart defects. And now we'll move on to nitric oxide. So you need to know the indications. And I guess we should say FDA approved indications. When you're putting an infant on nitric oxide, one of the questions asks you what the starting dose is. So when you turn on nitric oxide, how many parts per million should you start with? And then when you wait, of course, to see if O2 saturation improves. And then if it doesn't, you're going to increase the dosage. So I think it asks you for initial dose. Be familiar with methemoglobin. I don't know what the test question is, but it could ask you why you monitor methemoglobin during nitric oxide administration. It could ask you at what point is methemoglobin too high and you should reduce the amount of nitric oxide. And so that was it for methemoglobin. That was methemoglobin. And now for the next question, asks you what would happen if you turned off nitric oxide. Instead of weaning the nitric oxide, you just turn it off. What would happen to the baby? Okay, next question for nitric oxide. It asks, what is in the cylinder of Inamax? So is it all oxygen with a little bit of nitric oxide? Is it pure nitric oxide? Is it nitric oxide and something else? So make sure you look that up. And then there's a question, how can you tell if the infant is not tolerating their wean from nitric oxide. So let me type that. So how can you tell an infant is not tolerating their wean from nitric oxide? What would make you say, you know what? I went from 10 to 5 and that was not a good move. So what are you looking for? All right, so those are the questions that'll help you prepare for the nitric oxide portion. Next is ECMO. So let me clear all this and start over. So ECMO questions, you have to know the difference between veno-venous cannulation and veno-arterial cannulation. So we know that veno-venous cannulation, the right internal jugular vein is cannulated. Part of the catheter sits in the right atrium. Part of the catheter is sitting in the superior vena cava, I guess. Yeah. And then the blood is taken out of the superior vena cava and put into the right atrium after it's been oxygenated in the ECMO circuit. So the ECMO circuit will get rid of the oxygen. It'll get rid of the oxygen. I didn't say that right. It gets rid of the carbon dioxide and puts oxygen into the blood, and then the blood comes back into the right atrium. So by doing this, we're helping the lungs oxygenate the body, but it does nothing for heart function. So veno-venous cannulation is only for oxygenation and removal of CO2. For veno-arterial cannulation, blood is removed from the right atrium. So blood is still taken out of the body, but it's put back in after the left ventricle. So it's put into the arch of the aorta, because the other cannulation is going through the left common carotid artery. So it'll take blood from the right atrium and then put it into the aorta. And that way we're supporting heart function. And then this would be used in, they use it a lot after open heart surgery for pediatrics, for neonates and pediatrics. And then for adults also, but for veno-arterial cannulation, you have to know that that supports heart function and it causes a non-pulsatile blood flow. What else did you have to know about ECMO? I didn't write a lot of notes on ECMO. So I'm thinking it's indications for ECMO, like why would you recommend a patient have ECMO? Understanding the difference between veno-venous and veno-arterial. And there isn't a test question on it, but you're going to hear it a lot at the bedside, and that's talking about the sweep gas. And that's the ABG that gets drawn from the ECMO circuit right before the blood goes back into the patient. So that's how you know if the ECMO circuit is giving you exactly what you want as far as oxygenation and CO2 level. So that is it for ECMO. And I haven't come up with questions yet for Velletri. Some of the things I would want you to know about Velletri is that it behaves just like nitric oxide and other pulmonary vasodilators, where it dilates blood vessels. And I would also want you to know why it's given via inhalation instead of just putting it in a patient's IV and giving it intravenously. Mucoplastin. Okay, so you need to know that it's a pulmonary or it's a vasodilator. We give it via inhalation because we just want to dilate pulmonary vessels. We would give it to somebody who has right heart failure, and we're trying to help out the right heart by reducing pulmonary vascular resistance. So that was one indication we talked about. And then the other indication, maybe we did talk about more than two. So I will tell you to refer to your notes for that. The other one that comes to my mind is when you have pulmonary hypertension in the adults, then giving Velletri via inhalation, it will get absorbed through the alveoli that are functional, and it'll dilate the blood vessels around the alveoli that are working. So pulmonary vasodilator, it improves VQ mismatch because of the way that it works by inhaling it. And then the drug in the alveoli get absorbed by the capillaries and it dilates the pulmonary capillaries. And so that'll be it for questions on Velletri. Okay, that's all I can think of in my brain. So who's with me?
I
Hi,
think just
Rachel.
Hi, Yvonne.
Do you have any specific questions that you'd like me to touch on?
That's what I'm looking in my PowerPoints for right now, just to verify things. You're not going to put a question about the LVAD on the test, right?
No, there's nothing on LVAD.
Okay, because I know you just had like one slide on it.
Right.
And also, when I was doing the sheet, I could have sworn you talked about it, but for some reason, I'll have to double check it. The very last one on this sheet we had for home, the tricuspid atrasia. Did you have that in the PowerPoint?
Nope.
Okay. Are you gonna put that on the test?
Nope.
Okay. Then I won't worry about it.
Okay.
All right. No, everything else you gave good, like solid questions of what to look for. So I appreciate it.
You're so welcome. Thanks
Thank
for
you.
being here, Rachel.
No problem. Bye.
All right, I'll stop the recording.